Hi, everyone. Before we get started, for those that are live, you might have gotten an email from yesterday that between 12:05 and 12:20, everyone's going to get a text and a phone call about the emergency notification system. So just a reminder for those that are live to please put your phones on mute because our phones may all ring at once at like 12:07. So please put your phones on mute. Thank you.
Good afternoon, everybody. My name is Joshua Hare. I'm the Lewis Lemberg Professor of Cardiology and Medicine. It's my great honor and privilege to announce the 32nd Miriam Lemberg Lectureship in Cardiology. We're all very proud of the fact that this has been a very important academic contribution locally and for our national reputation in cardiology academics. I'm very pleased to have the Saltzman family here, Paula and Alan, and their son Russell. Paula is Lou and Miriam's daughter, and they've been wonderful supporters and attend the lecture every year. Just to briefly give you the history of this lectureship, Miriam Lemberg organized and did the fundraising for the Lewis Lemberg Professorship, presumably without Dr. Lemberg's knowledge, while he simultaneously was raising the endowment for this lectureship. So we're the Miller School of Medicine is very grateful to the Lemberg-Saltzman family for their incredible support of the academic mission in cardiology. Over the last 32 years, we've really had the who's who of academic cardiologists, and also have used this opportunity to honor our international leaders here within the University of Miami. We have had a tradition of having the current chief of cardiology give this lecture, and so it's my great privilege to have our new chief of cardiology, Dr. Chatzizisis, give the lecture, and he'll be introduced next. Thank you for being here.
Good afternoon and welcome to Medical Grand Rounds. My name is Michael Dongle. I'm one of the chief medical residents, and today I have the honor of introducing our Grand Round speaker, Dr. Yiannis Chatzizisis. Dr. Chatzizisis is a professor of medicine and the chief of the Division of Cardiovascular Medicine here at the University of Miami Miller School of Medicine. He earned his medical degree and PhD at the Aristotle University of Thessaloniki in Thessaloniki, Greece, and was trained in interventional cardiology and advanced non-invasive cardiovascular imaging at the Brigham and Women's Hospital in Boston, Massachusetts. Dr. Chatzizisis' clinical and research interests focus on complex coronary interventions with an emphasis on bifurcations, mechanical circulatory support, invasive imaging, advanced non-invasive cardiovascular imaging, computational cardiovascular simulations, and mechanical biology of atherosclerosis. He has authored more than 190 manuscripts published in Circulation, JACC, and Atherosclerosis, among other prestigious journals. Dr. Chatzizisis is a fellow of the American College of Cardiology, American Heart Association, Society for Cardiovascular Angiography and Interventions, and the European Society of Cardiology. He has received more than 40 national and international awards, including those by the European Society of Cardiology, European Atherosclerosis Society, American Heart Association, and Academy of Athens. He serves as an associate editor for atherosclerosis and pharmacology and therapeutics, and as a manuscript reviewer for the JACC and Circulation family of journals, among others. Today, Dr. Chatzizisis will be presenting on the digital transformation of cardiovascular medicine. Please join me in welcoming Dr. Chatzizisis.
Thank you. Thank you so much. Thank you, Dr. Hare, for the warm introduction. Thank you, Dr. Dangle, as well. I would like to take a moment here and share just a couple of words about this lectureship. Dr. Lemberg has been a trailblazer. He opened new avenues. He brought innovation back in time, and he shaped cardiology, the field of cardiology in the area. So this award signals our commitment in the pathway of excellence and innovation. I'm deeply humbled, and I would like to express my deep gratitude to the family, to the Lemberg family, for this recognition and for their unrestricted commitment to excellence and innovation. With that, I would like to move to my lecture, Digital Transformation of Cardiovascular Medicine. These are my disclosures. And that's the outline. So we're gonna, first of all, discuss the introductory part about the 21st century digital technologies, these computational tools that have the potential to change the landscape in medicine in general. And then we'll deep dive into the role of AI in cardiovascular medicine, computation simulations in cardiovascular medicine, extended reality, and of course, a little bit of provocative, if you want, glimpse into the future of how these tools, these digital tools can change the landscape of cardiovascular practice in the years to come. So we have put together this consortium of colleagues from around the world, all the way from Japan, China, Europe, US. And we had the honor to summarize all these digital technologies in this review that was published recently in JACC Interventions. So I refer you there if you want to dig further into the topic. And which are those technologies? It is AI, and I'm sure that everybody is familiar with this term. And there's some other members in this family, like machine learning and deep learning. We'll discuss about those. Computation simulations, and of course, extended reality. And we coined the term ACER in this review to encompass all these digital tools under the same umbrella. Let's see how AI is playing an important role in changing the game in cardiovascular interventions and cardiovascular medicine in general. So we live at the cusp of the fifth industrial revolution. That's the AI revolution. That goes beyond doubt. And what is AI? AI is, if I may, it's a mega brain. Essentially, it's a very interesting and very efficient way to democratize knowledge, to take the knowledge from an expert and disseminate this to the masses, to the non-experts, in a very democratized, very equitable way. So we have to see AI from this standpoint. And of course, it creates some anxiety, it creates some fear. Always there's biases and limitations, but we should never be blind to the evolution. We need to make ourselves familiar with terms which will be very handy in the years to come, like machine learning, deep learning, natural language processing. Those things happen every day in our practice. Cognitive computing, computer vision, robotics. So these are all under the big family of AI. And at the end of the day, this summarizes what happens with AI. So we need to have an input, which is called data. We have a system, the processing algorithm of the data, which is any AI tool. And then we have the output. And the output is essentially information that helps us understand better the pathophysiology of cardiovascular disease or any entity in medicine, better diagnostics and better therapeutics of cardiovascular disease. Deep learning, an important family member of AI. If I ask you, put a dog on my right and a cat on my left, and ask any of you to tell me what is on the right, what's on the left, you can easily differentiate. If I ask a machine, it cannot. However, as you can see here, the more data we fill this algorithm, this machine with, the higher the accuracy, the ability to differentiate between cats and dogs. And that's essentially the essence, the foundation of deep learning. So we need input, images in this particular case. We need the algorithm, and then the algorithm, the more data we feed the algorithm feed with, the more accurate is the output and the more reliable it becomes, the closer it gets to what we call human intelligence. So the foundation of AI is not only data, is big data. The more data we use, the higher and the closer we get to the human intelligence with the computer. What are those big data? It can be anything from the electronic health record, diet, genetics, wearables, anything. It can be anything from the imaging standpoint, But at the end of the day, everything comes into the bin of AI, machine learning, deep learning, computer vision, and gives us as an output information about the diagnosis, continuous remote monitoring, decision-making, treatment selection, precision medicine. And of course, we hope that the cost this way, the whole process is more efficient and the cost will be reduced. And the AI is founded on big data, and the AI is the foundation of precision medicine, precision cardiology, since we talk about cardiology today. So we go from the one size fits all, one therapy, one drug, one diagnostic approach fits all, to individualized approaches, which group number of patients, clusters of patients who are best diagnosed with specific diagnostic tool or are more receptive, respond better to a specific drug or specific treatment technique. Let's see some examples of how AI can change the landscape of cardiovascular medicine, starting from the basic science all the way to advanced therapeutics and diagnostics. AI can improve the workflow of cardiovascular genomics. We can have better understanding and diagnosis of the different variants. We can do the more reliable genotypic mapping. We can improve the quality of our DNA analysis. We can integrate information with clinical practice. We can come up with very reliable prediction tools based on AI extracted information from gene analysis. And these things would not happen without AI. It would be very cumbersome. Cardiovascular biomarkers. Different processes are shown here are reflected on biomarkers which circulate into the bloodstream. AI can help us identify those biomarkers which can be integrated in risk prediction models and allow us for faster and more accurate diagnosis and better treatment subsequently of different cardiovascular diseases. Very important. In the same vein, AI can also accelerate the processing of imaging biomarkers, imaging data. Using image processing tools based on AI, we can diagnose very quickly, extract very quickly different features from imaging, from calcium score and so on, and then integrate this with clinical mapping, phenotyping of our patients, and come up with very reliable, more precise risk stratification tools. Also, AI can play an important role in advanced treatment and therapeutics, as shown here. Automatic segmentation of images, intravascular images, to guide our coronary interventions, identification of calcium automatically in a heartbeat of an individual coronary artery, which is very important to guide the therapeutic plan. AI can feed the robot to achieve what we call consistent and reproducible delivery of therapy versus interoperator variability. So now let's switch gears and go to the role of simulations, computation simulations in cardiovascular medicine. As you can see here, these are the three types of simulations. We have on the left, live simulations, like in this Japanese kindergarten, this fire drill, real players in a real environment, simulating a process, which is called fire drill. Virtual simulation, when we have real players, like in this flight simulator, in a synthetic environment. This person doesn't fly a real plane. Or computation simulation, when both the player and the environment are synthetic. And that's where we would like to focus more. What is computation simulation? As shown here is a simulation that runs on a single computer or a network of computers. And this cluster of computers reproduces the behavior of the system. And the simulation uses a computational model to simulate the system. We have simulations all over life, from entertainment, filmography, Star Wars, Matrix, 300, Lord of the Rings, everything. Avatar has been heavily dependent on simulations. Video games, Disneyland, automobile, biomechanics, economics, engineering, aviation and space industry, marine, sports, weather, medicine, of course, including cardiology. So simulations are all over. And that's very fundamental slide. It shows what we call digital twins. as you see here, that's a traditional way of extracting knowledge, real systems where we perform real experiments and we extract real experimental results. Now we have a model, which is essentially a digital replica, an in silico replica of the real system. And this model is used to perform simulation studies and extract simulation results. And the beauty here is that as long as we have a model, which is a very faithful replica of the real world, then these results can be faithful compared to the experimental results. And we can validate those. As long as we have such a real system, then imagine how many infinite scenarios we can run in a very time and cost-effective way to come up with new knowledge and improve current theories. And at any point in time, we can go back and validate this new knowledge against real experiments. Now, let's see how these simulations can play an important role in different aspects of our cardiovascular operations. Let's start from the core interventions. Pre-procedural planning, very important. By failing to prepare, said by Benjamin Franklin, we're preparing to fail. Let's see how simulations can help us plan our procedures. So the whole concept is here. As you can see, we know very well that stent interventions, they have adverse outcomes up to 20, 30% sometimes over 5 years. Patients come back with restenosis, stent thrombosis, some of those die as well. So we need to come up with a more individualized, more personalized approach that uses the individual anatomy and physiology in planning the procedure. What's the best way, the most cost and time-effective way to plan a procedure other than computational simulation? So that's essentially the concept that we put forward. And through our federal funding, we have put together and patented this standing platform where we use real input from interventional imaging. And then we create this in silico, these digital twins of the coronary arteries with lumen and wall anatomy replicated computation. It's like taking the artery from the body into the computer in a very faithful way. And then not only this, we integrate the materials, the wall materials coming from imaging. So not only anatomy, but also biology is there and physiology as well. And this triplet is essentially the foundation, the digital twin, where we use to do our simulations, enter their realistic stent designs, material-wise and size-wise, balloons and so on, and do the stenting procedure computationally in a very faithful way, in a very patient-specific way. And the outcome of these simulations is any biomechanics or stent morphometry. And there's multiple applications of this, primarily planning of procedures. Again, that's a little bit more info on how it operates. We combine different imaging modalities to create the digital twin. And then you see here the distribution of material, the calcium, the fibrosis, the fibrolipid material in 3D. And then we go one step further and we translate this distribution of materials into stiffness mapping. Because at the end of the day, stent encounters stiffness. And we make decisions about stent procedures based on how stiff is the vessel. That's what we need to know at the end of the day. And you see here, it's not 0 or 1, it's like the whole spectrum of stiffness mapped in a very individualized way on this digital replica of the coronary arteries. Now, so what? I'm sure, including me, we would ask, okay, enough with this theory, but how this translates. I'll show you here a very direct translation of these concepts into interventional cardiology. We have a series of what we call all simulation guided left main PCIs. This is one of the cases that we have performed. That's a 60-year-old woman with significant left main disease, shown here by angiography and by intravascular ultrasound. What we did, we stopped, we took the patient off the table, we created the digital twin, again, the faithful replica of the coronary artery, the verification of the left main, with the lumen, the wall. You see the stenosis here. You see the flow computationally. You see the flow acceleration across the stenotic left main. You see the mapping of the materials and the stiffness on this digital replica. And then we enter the whole thing into the simulation platform. and let the system decide about what's the best stent technique and sizing and positioning for this particular individual. For this case, for example, pre-dilate with this balloon, one stent across the left main to the LAD, no second stent, and then post-dilate here. And this gives us good result computationally. We haven't touched the patient yet. So this is also indispensable for the patient to know what I would expect in this procedure versus the black box. So what we do now, at this point, in a very, I would say, provocative, radical way, we go back to the patient. And as you see here, this is what the simulation, what the AI predicted, recommended, and that's what we did. We executed faithfully to the dot every single step of the simulation. Shown here, the predilation step, exactly the same balloon, lengthwise, atmosphere inflation-wise, same stent, same post-dilation technique. And here is the final result. That's the baseline angiogram, and that's the post, all simulation-guided procedure. Patient went home. 3 years later now, patient is doing very well. We escaped bypass surgery, and maybe that's a way to start thinking for our operations in the years to come. And we have a series of those patients. I'm going to how the simulations can help us with bypass surgery, not only percutaneous interventions, but also surgical interventions. Again, the same concept. Now we create digital twin, which incorporates the aorta, the coronary arteries, the great vessels. And what we do, we create a computational graft. So we bypass computationally in the computer the stenosis to see how the flow is going to be in the native artery and in the graft after the computational grafting. And that's important information because only then the surgeon can make better decisions about the number of grafts and the type of grafts, hoping to achieve better graft patency and better clinical outcomes. So that's something that is one of our priorities as well, to guide surgical interventions using simulations. How about structural interventions? A very, very growing operation here. As you can see, transcatheter aortic valve replacement in the same concept, a digital twin of the aorta to decide the best valve type and valve size for your individual. Same for the mitral valve repair, same for the left appendage occlusion. See here an example, individual aorta reconstructed in silico, and we have ample time here to let the simulation and the AI decide about the best valve type and valve size to secure the best apposition, to minimize the risk for AI, to minimize the risk for occlusion of the coronary arteries, to minimize the risk for conduction abnormalities. And that's very important, to tailor the therapy to the individual anatomy. Same with the appendage occlusion here. The left atrium out of the body into the computer. We have 7 billion population, 7 billion different appendages on this planet. And we have to identify for this particular appendage what's the best occlusion device type and what's the best size, as shown here. How about device R&D? Not only planning of procedures, but also use simulations for device R&D. This comes from the FDA. As you can see here, this is the so-called total product life cycle, okay? That's the R&D phase from the inception all the way to FDA approval and post-market monitoring. And throughout the whole life of the product, we can use simulations to predict the performance of the device and post-marketing to assess the performance of the device in real patients. See this very interesting concept here. Again, this comes from the FDA, and it shows clearly that that's how animals perform in the assessment of devices. That's bench testing, and that's computer testing to assess the performance of the device. And then you see here, green means good, red means poor. And you see that the computational simulation has big advantages compared to animals and bench when it comes to predict the performance beyond the indication for use. When it comes to ability to vary parameters, it's very easier, much easier to dial up, dial down different parameters in a computational model versus running animal studies. For example, I can increase or decrease the calcification of a coronary artery in a computational model. I cannot do this in an animal model. Every time I need to build a more or less calcified animal model, I need to spend a lot of time and money to do this. Also, you see, simulations can help us with cost and time. And that's the beauty. And the FDA right now pushes in favor of using simulations for device R&D. And in the years to come, maybe the animals and bench testing will be eliminated significantly. This is a very humble experience from us, from our group, on how you can use simulations to drive the device R&D. That's from a company, 3 different prototypes of a stent. This is before the FDA approval of this particular stent. 1 prototype with 9 peaks. These are the peaks. 2nd prototype, 3rd. The company right now is negotiating internally what's the best design to go through the FDA. And what we do, we essentially use the simulation approach to test the performance of these prototypes in patient-specific left mains coming from real patients, where we have replicated the anatomy, the lumen, the wall, and the materials. Again, patient-specific data to test different prototypes. As you can see here, we do what we are doing very well with our simulations. And then the final result, which goes beyond the expertise of this group here, but I just want to tell you that the final result is that this particular prototype with 12 peaks had better performance compared to other prototypes in terms of expansion and scaffolding and important mechanical performance metrics of the stent, which means that the higher the ability to expand the stent, the better the outcomes down the line. So for those reasons, and along with some other internal experimentation in the company, finally the stent, this particular 12-peak stent, ended up through the FDA, successfully cleared, and now it's commercially available. So this humble experience shows this concept of synergy between academia, us, industry, them, and FDA. And that's, in my fair opinion, one of the opportunities we have here at the University of Miami to drive innovation and excellence, to partner with industry, to partner with FDA, and drive the device R&D. Now, let's switch gears to go to another interesting concept, how simulations can help us with the regulatory approval, not only device R&D, but also approval through FDA of devices. As you can see here, this is some facts about clinical trials. You know very well, better than me, that we live in the era of evidence-based medicine. There's no practice without evidence, without a randomized clinical trial, but also the RCTs, the randomized clinical trials, have limitations. Some of those are shown here. Underrepresentation. I'm not quite sure Greeks or Indians or Japanese or name it are so well represented. Women, let's be honest, in these big clinical trials. Increased dropout rates, not only in cardiology, but in general medicine. Clinical trials have issues to come into fruition, to completion. Up to 20% data from 2015 show that trials are either prematurely stopped or they're delayed. And guess what? When you delay, you spend more resources and money. So there are limitations. And the question is how we can get smarter to improve this gift of randomized clinical trials. We introduced the concept of virtual clinical trials, and also FDA right now is pushing towards this direction. So see the concept. You have different devices, different techniques, name it. We don't go to a trial directly to test the devices or techniques, which is going to be, as I said, very expensive, with high dropout rates and possibly underrepresented. What we do is we run a large-scale computational, virtual, in silico clinical trial, where we use diverse patient anatomies, patient data. It's easier to find 2,000 left main bifurcations from India, Greece, Peru, US, versus 2,000 actual patients from these places. And we don't obviously have clinical outcomes, but we have simulation endpoints, which are very highly predictive of actual outcomes. So we take advantage of the knowledge that we have already garnered, that, for example, stent expansion predicts stent stenosis and death. Now, we don't have a clinical outcome in the trial, but we have the stent expansion as a simulation endpoint, a surrogate endpoint to predict the clinical outcome. So with this approach, we can filter down the techniques and the devices to the best ones. And then we go to an actual clinical trial with real patients and real outcomes, but now in a more targeted fashion. After getting the signal from the virtual trial, you go to an actual trial in a more targeted, more sophisticated way, and that's how you can advance the science in a very cost and time-effective way. So essentially, we propose here, and this comes again from the FDA, a different approach on the generation of knowledge, using simulations, computational simulations, to run in silico virtual clinical trials to inform FDA, industry, academia on the best devices, the best techniques. And that's how we can come up with scientifically impactful new knowledge in a very cost and time-effective way. So we garner better knowledge and we save money and time. This is our humble effort through our federal funding, a small virtual clinical trial to find out what's the best technique for coronary artery bifurcations. We use anatomies from diverse population, from Asia and Europe, and there's no way that you run the same stent technique in the same individual. I'm sorry, more than one stent technique in the same individual, right? But we can do this computationally. So we run different techniques in the same anatomy, and we have those endpoints, biomechanics and stent expansion and so on. And we create essentially an atlas through the NIH, is publicly available, of simulations and anatomies. And at the end of the day, what we try to do here is to find groups of bifurcation anatomies which are best treated with specific stenting techniques. And that's indispensable knowledge for those who are in the field. Is a big, big question nowadays, and we really look forward to this kind of information. And then finally, I'm going to move to the role of extended reality in cardiovascular medicine. What is extended reality? Is a big, big umbrella, big family. With virtual reality means I have my headsets, I'm lost, immersed in the virtual world. Unless somebody's around me, I might bump the wall. Augmented reality means that now I have full understanding of the surrounding, safer for the operator. And then, of course, mixed reality is something in between. So see here, this extended reality, X reality, as Z generation calls it, we can tailor our interventions. You see here, this is a human being in a huge room, seeing like a red blood cell from the inside and from just the wall. The flow within this stented, this mega magnified, zoomed out coronary artery. Same structural interventions. The operator in front of him or her has the hologram of the anatomy. Same with peripheral. Same with education and training. And let me show you some examples here. This is like an operator within the cave, within a room, which is surrounded by the stented coronary artery. So like a red blood cell with a camera inside. We need to prioritize a different model, brand a different model. We're going to do this here in Miami, since we're trailblazers, of teaching our learners. A model that is using simulations and extended reality to help our trainees learn greater, faster, better. These are the three keywords. Greater, faster, better. These are like few bucks from Google to buy, and everybody here with like $100 can get those. All together with $100, each of you, all of you can get this total bill, this headsets, hook up the cell there, and then follow me in the trip through this. See, this is the cath lab, our cath lab, any cath lab, where my hand, that's my hand, the blue, plays around with the eye of the angiography machine. It turns around, different projections. You get to see how it works in different projections. How is a coronary artery? How does it look like? No X-ray, no contrast. Spend your day over there. Seeing is believing. You spend 1 hour there, you're already familiar with what you're going to encounter in the actual clinical arena. Otherwise, the only alternative is to learn on the patient. And guess what? This comes with complications. For more advanced operators, different techniques. We discussed this the other day as well. From the outside, how each technique works here. From the inside, you get to see how the stent, this is like 70 microns thickness, and you get to see it from the inside like a red blood cell, how it interacts with the wall, with the second stent, and so on. Again, indispensable experiential learning that can take you to the next level of learning. We like books, we like videos, but this kind of experiential learning is different level. That's what we deserve for our learners nowadays. Another more advanced technique here to see now the second stent coming here to see how it interacts with the first stent and so on. So we acquire important cognitive information that helps us to become better and deliver better care for our patients. And keep in mind that those three, AI, simulations, and virtual extended reality, they're not independent. They are interrelated. That's why we use the term ACER. One interacts closely with each other and one influences the other. So I'm closing with a little bit of provocative, if you want, glimpse into the future of cardiovascular practice. And that's how we feel that it might go, hopefully in the near future. We use imaging, which is available. We don't invent the wheel, but we squeeze the lemon. There's lots of information there which goes untapped. So we need to dig into this information, whether it's invasive or non-invasive imaging, and let the AI, instead of the human eye of an expert, because I'm an expert, but somebody else is not. And we're so dependent on the expertise of somebody. We let now, through this democratization of knowledge through AI, to identify in a very consistent and reliable way coronary, peripheral, or structural disease abnormality that requires therapy. And then we feed this information into the simulation for the so-called AI-driven intelligent applications and simulations to identify the optimal, personalized treatment strategy for every patient in real time. And that's keyword here, because we like the offline operation, but it's even better when at the point of care, in the cath lab, in the echo lab, I have diagnosis in a very consistent way. And at the same time, I have a AI-driven recommendation for the therapy in real time. And then we fit this into the robot. And don't get stressed by the idea that a robot is going to do the procedure. We're there. We're there for the complications. We're there to supervise. But the robot secures the consistency, the reproducibility versus this amazing and big interoperator variability, which is essentially the foundation of complications. And we hope that with this approach, we will generate guidance for procedures to the operator, improve the workflow in the cath lab, improve patient satisfaction, staff satisfaction, doctor satisfaction, decrease the healthcare costs, and at the end of the day, the pinnacle, the ultimate judge of what we do is called improved clinical outcomes. And don't get me wrong, nothing is easy. There's lots of limitations, barriers, biases. Some of those are here. Data biases, as I said, all these simulations and virtual reality and so on are heavily based on big data. If we don't have big data, we'll have biased information, biased therapeutic plans, biased recommendations. Financial barriers. It's expensive, as it's the case with any new technology. Accessibility. We access this here in this beautiful ecosystem at the University of Miami, which is so forward thinking. I'm not quite sure in the Aristotle University of Thessaloniki, where I was trained, this is accessible right away. Technical limitations. it's all virtual. There's no tactile. Tactile is important. One of our senses is like, tactile. It's very important. And then, of course, legal. Patient dies after a simulation recommendation. Who's responsible? The machine or the operator, or both? So that's a graphic summary as I close my lecture. The AI simulations, computation simulations, and extended reality, they're here to help us, to assist us with planning of procedures, to deliver more personalized, more consistent, more reproducible, more accurate, more precise procedures. They're here to help us with device design, R&D, and technique optimization. They're here through virtual trials to facilitate actual clinical trials, to generate new knowledge and pass through the FDA and other regulatory bodies in a very time and cost-effective way. And they're here, of course, for you, for the learners, to learn greater, faster, and better. And take-home messages, number one, new digital technologies, AI, simulations, extended reality are feasible in the practice of cardiovascular medicine, in general medicine. AI is the primary tool that helps us with the diagnosis and treatment of cardiovascular disease. And it can be essentially the foundation, the tool to dig into the big data derived from clinical trials, which is available information. Simulations, computation simulations are helping us with the pre and peri-procedural planning and teaching, of course, for our learners. And then extended reality is the toy to plan procedures and help our learners to learn greater, faster, and better. And all three, AI, computation simulations, and extended reality, have the potential to change the practice, the clinical research, the device R&D, the approval of devices, and training or in cardiovascular medicine in the years to come. A big thank you to my group, a group of engineers, programmers, top class intelligent scientists who are experts in AI and mathematics and visualization, vascular biologists, and top class, very intelligent medical doctors. That's my group. The Center for Digital Cardiovascular Innovations at the University of Miami. We're based in Converge. A big thank you, obviously, to federal industry and philanthropic resources. And with that, I would like to thank you so much for your attention and for this honor to be the recipient of this prestigious award. Thank you.
Thank you, Yiannis, for a beautiful presentation. I can't help but think it reminds me of when I was a little kid and went to the World's Fair and saw the GE, that was General Electric, exhibit. And I looked at all the things and I said, no way, this is somebody dreaming and it'll never happen. And that was just the concept of having an ice maker in the refrigerator. Today, you've taken this quite a different level. One thing I'd like you to comment on, which is potentially one could have as a concern, as you develop these algorithms and the big data, and you look into getting the FDA to approve virtual trials, one can't help but think the importance of engaging the patient population in terms of their acceptance of this new paradigm of understanding how we're going to move medicine in the future. One can just look most recently at our pandemic and how technology advanced a vaccine, and yet that turned the public, some of the public, against it. How can we engage our patient population to buy into the technology that you're proposing so that it then can become part and parcel of our armamentarium?
Yeah, that's a very key question. Thank you so much, Dr. Weiss. How we engage our patients, the community. That's in part our duty. Our duty as academic institutions is to open these new avenues and through interaction with other academic institutes, through interaction with industry, through interaction with FDA, send the message in a very digestible way to the masses, to our population, to our patients, that what we do is in your benefit, is in your favor. It's called advancement in medicine. We don't replace any clinical trial. We don't replace any patient, but we definitely try to facilitate those in a more targeted way to save money, to save resources, and come up with more meaningful knowledge. So it's a matter of awareness, essentially, of to the public, that what we do is simply called advancement, in the same way that vaccines, not this vaccine for COVID, but back in the past, came out and saved lives. In the same way that the ICD saves lives, in the same way that the stents or any intervention, in the same way that the new pharmacotherapies for hepatitis B or C save HIV as well. So without this concept of advancing technology and opening avenues, we would have HIV or other diseases today treated. So that's how I think we should make our public aware. But again, it's an effort, and it's not easy, because the rigidity on both the operator side, it's very difficult, Dr. Weiss, to convince the operators as well to adopt these technologies, as well as on the side of those who are kind of like get the benefit from the intervention, which is essentially the patients.
Thank you, Yiannis. That was just exceptional and very thought-provoking. I have a very basic question. What kind of software and programming ability does somebody or a group have to get into this area with a new concept?
I was expecting a question how much it costs, because you said it's going to be direct. So the software infrastructure is something actually easier. It's called computer power. This concept, I would say 5 years back, 10 years back, even worse, wouldn't be. My lecture would be outdated, would be futuristic. It's not futuristic today. It's realistic. It's the near future. It requires computer power, and we have it. We run in our campus one of the faster computer clusters. So we have the power. Power is available. As long as you have the power, then all these technologies can be accelerated, and this idea of real-time guidance is now a reality.
What do you